Hi, I hope you've had a really good day. So I'm going to be talking today about thyroid disorders and how they can interfere with the perimenopause and menopause and our own hormones. I've had lots and lots of questions about this and lots of people come to the clinic asking about it. So I thought I would just go through some basic science like I have done in other weeks, just so that you understand what our thyroid gland is, what it does, what the hormones are, and how they can interfere with our sex hormones as well. So I'm just going to take it right back to the basics first of all. Our thyroid gland is in our neck, and it's like a butterfly shape gland, and so it has different lobes on it, and basically what it does is it produces our thyroid hormones, and they're numbered actually. So the main one that people have heard of is thyroxine, which is T4. There's also T3 as well, and then unsurprisingly there is T3, T2 and T1, but we know most about T4 and T3. Also in the thyroid gland are these tiny other glands called parathyroid glands, which are associated with our calcium metabolism as well. But I'm going to concentrate just talking about the thyroid hormones. So our thyroid hormones are really important for our metabolism, so how we burn off energy and how we use energy in the body. So unsurprisingly, our thyroid hormones are just hormones. So as I've said before, hormones are chemical messengers. They go into the bloodstream, go all around our body and affect every single cell in our body, and our thyroid hormones are no different. They get produced in the thyroid gland, enter the bloodstream and then go all around our body and have very important effects throughout our body. Now, we don't have the same level of thyroxine every second throughout the day and night. It's constantly changing, and like I've said before, all our hormones are changing. They change in response to other hormones having an effect on them, but also what's happening within our body, what we're eating, how stressed we are, what we're doing, whether we're doing exercise, whether we're sleeping, all sorts of things that can occur, and our hormones all work together. Now, I found this picture just on Google, which I will try and get on my stories if I can, but it basically shows the effects of the thyroid hormone. And so basically, what determines the thyroid, how it works, is actually our hypothalamus, which is part of our brain, which produces other hormones, and it produces a thyroid releasing hormone, which then affects on the pituitary gland, which is another really important area of our brain that produces lots of hormones. And it has what's called, it affects the, it produces something called TSH, which is thyroid stimulating hormone. So you've got thyroid releasing hormone from the hypothalamus, which then works on the pituitary gland, which produces thyroid stimulating hormone, which then goes directly and affects the thyroid gland, producing the thyroxine hormone and the T3 as well. And there's this feedback that goes on all the time. So if the thyroid or the body is signaling that it needs more thyroxine, it will stimulate for more TSH to be produced by the pituitary gland. If the body senses that it needs less, then that feedback will happen, so there'll be less of the thyroid stimulating hormones. So there's constantly having this very fine-tuning sort of work going on. But the thyroid stimulating hormone doesn't just affect the thyroid actually, and this is why I printed this out, because I think it's very interesting. It also produces, you'll see here is a picture of a womb, so it actually affects the lining of the womb. It also affects the ovary as well, and if someone was pregnant, it affects the placenta. There's also an effect here, there's a dotted line here, and it affects the adipose tissue, the fat tissue as well. But if you think how it affects the lining of the womb, is very interesting actually. So if people have a raised TSH, thyroid stimulating hormone, then they can get, it says here, increased endometrial thickness, so the lining of the womb thickens, there can be some contraction of the womb, and also it has an increased estrogenic response. So actually it increases response to estrogen in the lining of the womb as well. And also then it can also affect the ovaries as well, and it can increase the risk of cysts developing as well as proliferating some of the cells as well. And the thyroid over here, you'll see there's a picture of the thyroid gland as well, and it's acting on all these areas in our body. And this is really important when we think about how our thyroid hormones can affect our reproductive system as well. There's a picture of the liver as well, and the liver produces something called your sex hormone binding globulin, and that can raise or reduce depending whether your thyroid is overactive or underactive. So all these are important when we're thinking about how does our thyroxine, our thyroid hormone, interfere with our estrogen, with our FSH, our follicle stimulating hormone, and also the direct organs as well, so the womb and the ovary. And you can see here very closely affected. And that is important when we think about who gets thyroid disorders. Now, around 14% of all women will have some thyroid disorders. That's really common. And the incidence of women compared to men is a lot higher in women. Around 3 to 5 times more likely is that women get thyroid disorders than men. And people can get underactive or overactive thyroid glands. Very common, and more common when there are triggers, and these triggers can, wait for it, be related to our hormones. So when people are going through adolescence, when people are perimenopausal or menopausal, also when people become pregnant as well. And that's probably because these hormones work very closely together. And so often when people become pregnant, people monitor thyroid function, especially if people are having symptoms suggestive of an underactive or overactive thyroid gland. With heavy periods, we often then also we'll look at a thyroid test to see whether the thyroid's related at all. So any hormonal changes can trigger the thyroid to be underactive or overactive. Also viruses can affect as well, so it might be a temporary dysfunction, and any stress. So quite often actually when I was working in a hospital and people came in with a heart attack or a chest infection, very unwell, they would often have abnormalities in their thyroid function test on a blood test, and that would often normalise with time. So if the body's under a lot of stress, it can affect the way the thyroid's working. So sometimes we get what's called a subclinical hypothyroidism, which means that it's not doesn't need immediate treatment, but we have to monitor it. And that's no surprise when you think about how our hormones all work together. But there are a lot of women who do have underactive or overactive thyroid disorders that aren't being picked up. If you look at the symptoms of underactive thyroid, so hypothyroidism, then the symptoms are numerous, but they can include fatigue, muscle and joint pain, putting on weight, having hair and skin changes, feeling more anxious, skin can become dry, I think I said that already, brain fog can occur as well. Overactive thyroid gland, people can be very anxious, they can be restless, they cannot sleep so well, they can be sweaty, they can be losing weight. Now actually, if you put all these symptoms together, underactive and overactive thyroid, a lot of them are very similar to symptoms of perimenopause and menopause. Now, I've already said many times before that there isn't a diagnostic test that we can do, like a blood test or a saliva or urine test, for the perimenopause or menopause. There are tests that we can do for thyroid, and so often, certainly in our clinic, we'll often do baseline blood tests which will include TSH, T3 and T4 levels, which can be really useful. Sometimes in other clinics, especially in the NHS, they only allow people to have the TSH level, which is the thyroid stimulating hormone level, which can give a guide, but actually you can still have changes in T4 and T3 and have a normal TSH level. So if someone is suspecting that there's a thyroid condition, often they will ask for a T4 and T3 level. But like our own hormones, our estrogen and levels, there can be fluctuation as well. And there is quite an academic debate with different doctors as to what level you would start treatment at. And I've read so many papers and people seem to disagree. And I'm not a thyroid specialist, so I'm not going to give you absolute levels. Often with any blood test in medicine, it's in conjunction with the patient's history and the way that they feel as well. And sometimes I know some thyroid specialists will actually give a therapeutic trial, which means they'll try T4, the thyroxine, or sometimes they'll give T3 and assess this response in conjunction with doing blood tests as well. And so many people do go and see a thyroid specialist if they feel that they are having symptoms and their blood tests are sort of borderline, or there's been some uncertainty how close to being abnormal they are. And hormone levels can often change a lot, so they're only giving a little guide as well. So a lot of people find that their thyroid function changes, as I say, during perimenopause and menopause. And during the perimenopause and menopause, our own hormone levels are fluctuating and declining. So our estradiol level, a good form of estrogen, progesterone and testosterone levels are reducing as well. Now, as I've said before, these three hormones are also biologically active. They also affect every single cell in our body, and there can be some overlap with what our hormones do, our estradiol, progesterone and testosterone, with what our thyroxine hormones, our thyroid hormones do as well. So if our body isn't getting what it's needed from the estradiol, progesterone and testosterone, then it might lean a bit heavier onto thyroxine and say, come on, thyroid gland, do a bit more work, because we need the metabolism of some of these biological processes improving. And so it's a bit like when I said when people become unwell with a chest infection or have a heart attack, there's extra strain and stress on the body. And so often in the clinic we will see people that have abnormal thyroid function tests, but they're also perimenopausal and menopausal. And often what I tend to do certainly is give back the estrogen, progesterone, testosterone in the doses that's needed for that individual, and monitor the thyroid function tests. And then often the thyroid function test will improve. And so it's important that we don't rush and give lots of different hormones together, because actually sometimes giving the sex hormones back actually means that the thyroid can just calm down and then work quite nicely as well. Sometimes people can also have an underactive and overactive thyroid gland and be perimenopausal or menopausal. So it's important we're not just saying, oh, it's all related to your perimenopause and menopause, and we're not considering thyroid as well. And certainly as a GP and a physician, I'm very used to dealing with more than one endocrine disorder. So it is important that everything gets looked at properly. Now, there are different treatments if people do need treatments for underactive or overactive thyroid disorders. A lot of it depends on what the cause is. So if someone has an overactive thyroid gland, there might be more tests that are done, certainly on the thyroid, to see what's going on. Is there an area, like a small area in the thyroid gland that's being overactive? Some people can have like a little adenoma, so a little growth that's usually benign, it's not cancerous, but that area can be more hyperactive, if you like, in the thyroid gland, or it could be a diffuse swelling. Like I say, sometimes it's temporary, sometimes it's permanent. Often, if it's very overactive, we give a drug. A commonly used drug is something called carbimazole. Start on a low dose and just monitor and see how thyroid function improves. Sometimes if that doesn't work enough, or it's going to be a longer term problem, then sometimes people are referred to have radioactive treatment, so radioactive iodine actually, which then stops the thyroid working. Sometimes it stops it working so much that the people then have to have thyroxine afterwards to replace the thyroxine and maybe T3 as well that the thyroid would otherwise be producing. So it really depends on the underlying cause and the treatment as well. Sometimes people have thyroiditis, so inflammation of the thyroid, and it can be short term, so even after a pregnancy. So when the baby's born, the thyroid can become very active and then it can settle down with time. So you wouldn't rush and give radioactive iodine to those women. If people have underactive thyroid gland, so hypothyroidism, then we often just give the replacement hormones. So usually start with thyroxine, and there is still some debate out there about giving T3, which is the other hormone, and some people have Armour, which contains the other types of thyroid as well. There's debate out there, and it's mainly when there's uncertainty. It's often because the research hasn't been done, and certainly when I've been looking at studies, there hasn't been really good quality evidence, which is crazy actually when it's something that's so common. I've already said 14% of women have thyroid disorders, yet the research is quite scanty, especially when looking at the ideal replacement and long-term problems with under-replacing or even over-replacing with the wrong hormone. So it's important that the treatment is individualised by someone who really understands thyroid conditions. Some people have been asking questions about, well, if you're on thyroxine or you're on or carbimazole, for example, if you've got an overactive thyroid, can you still take HRT? Now, actually, yes, of course you can, but usually we recommend the body identical HRT. So the natural estrogen, so the transdermal through the skin estradiol, which is a patch or a gel, and also the natural progesterone too, the Utrogestan in the UK, the micronized progesterone, and testosterone, either a gel or cream through the skin, because these are all the natural, the same biochemical structure hormones as the ones we produce when we're younger, and they won't interfere with thyroxine. As I mentioned before, the liver produces sex hormone binding globulin, SHBG, and that can change if people have oral estrogen. So tablet estrogen can sometimes interfere with the way thyroxine works in the body. So we usually recommend to have the transdermal estradiol with the natural progesterone as well. So it doesn't usually interfere, but some people find if they've already got a thyroid disorder and they're on treatment and then they become perimenopausal, then their thyroxine or their thyroid treatment might need tweaking as well as adding in HRT. But there's certainly no reason why you can't have HRT as well. And I see a lot of women who have been just put on more and more thyroxine, and it's become very out of control, their thyroid disorder, and no one has thought about how their HRT should be optimised. We also know that a lot of thyroid disorders can be autoimmune. So autoimmune means when the body's immune system sort of fights itself, if you like, and there are quite a few autoimmune disorders. Type 1 diabetes is thought to be autoimmune. Rheumatoid arthritis may be autoimmune, and also a lot of women who have POI, premature ovarian insufficiency, might be related to an autoimmune condition. So I'm just telling you this because if someone has POI, premature ovarian insufficiency, which is menopause under the age of 40, we usually screen for thyroid disorders at least every year, and we usually do autoantibodies as well. So you can do antibodies to the thyroid gland, if you like, to the tissue, to see if people are more predisposed to having thyroid disorders. So it's very important that if you have been diagnosed with menopause at a young age, that you have your thyroid function measured regularly, because you have got an increased risk, if you like, of having thyroid disorders as well as other autoimmune diseases, including celiac disease actually. So it's just something to be aware of as well. Anything that's autoimmune diseases, I've mentioned before, are more common in women than men, and so a lot of it will be related to our hormones. So we've written some information about thyroid disorders and hormones on a Balance website, and I'll share the link afterwards. But I just wanted to just highlight actually that it's these two disorders, so thyroid disorders and obviously perimenopause, menopause, can be very, very common, but it should be made very simple. Ideally, you should see someone who understands both hormone pathways and work out which one is the most important, knowing that the two interlink. So it's often not just looking at one in isolation, because you're not going to complete the whole picture, and you're not necessarily going to feel completely better if you only take thyroid hormones when you need estradiol, progesterone, testosterone, or you're not going to feel completely better if you only take your sex hormones if you've got a problem with your thyroid as well. So it's really worth optimizing everything together and see someone who really does understand the hormones and how they work. So that's quite a short Instagram live today, but as I've said, I'm not a thyroid specialist, but I have seen and helped a lot of people over the last 30 years or so of being a doctor with thyroid disorders. But actually, when I used to work in an endocrine clinic many years ago in hospital, I didn't know anything about sex hormones. No one taught me anything about it. But the more we learn, the more you realise the close association of these hormones. And actually, frustratingly, how few women are really being listened to when it comes to thyroid disorders, as well as our sex hormones being out of kilt. Finally, before I finish, I just wanted to talk about PCOS as well. So polycystic ovarian syndrome, which is more of a metabolic syndrome, really. Different ways of diagnosing it, very common, and it can be associated with thyroid disorders as well. It's probably the mechanism, the sort of pathophysiology can be linked with the way these hormones can affect our thyroid. But really important, if someone has got PCOS, then looking very closely at their thyroid hormones to be optimised as well, because otherwise their symptoms related to PCOS aren't necessarily going to improve. So important to think about that as well. So I hope that's been useful. Lots of information there, I realise, and I think it's important to go back to basic physiology so that when you understand how our bodies work, it's easier then to understand why they don't work and what happens, and more importantly, what we can do about it. So I hope you enjoy. If you're in the UK, it's Bank Holiday Monday tomorrow. I hope the sun shines, and I hope that's been useful. So thanks very much and enjoy your evening.